עברתי מקום.
So after this fascinating presentation with so much information with regards to what's happening around the world and in Israel and what we have to do, so why don't we focus on the local arena and the local level? We're going to talk about the inequality in health, again, report. And again, we have a few ministries here, but of course the leading minister when talking about health inequality in Israel is of course the health ministry. And of course the collaboration that this does with the Ministry of Welfare and the Ministry of Education is absolutely amazing. But I think that that's a process that we have to focus on inequality as a multi-dimensional topic. I don't think there are many ministries of health around the world that lead this issue. And I think that we've reached a conclusion that we have to renew the strategy as far as this is concerned. Maybe the strategy in the past decade is no longer relevant for our decade. So hopefully in the next session we will hear the recommendation of this report. The chair will be Professor Nadav Davidovitch, who is the principal researcher at the Health Policy Program Chair at Taub Center and the head of the School of Public Health at Ben-Gurion University. Is also the chair of Public Doctors in Israel and a member of committees belonging to the Ministry of Health, and with Ayelet Grinbaum-Arizon, who is a Senior Deputy Director General for Strategic and Economic Planning in the Ministry of Health and deals directly with diminishing inequality. She basically coordinating the entire approach of inequality in the Ministry of Health. She also coordinated the COVID crisis and helped the public. She is responsible for many areas, and I think she focuses on many areas. We'll then be hearing from Professor Nachman, who was a military doctor, who was Director General in the Ministry of Health. He also was a consultant in many HMOs, and during COVID times, of course, hoping that it's over, he was the head of the national program for combating COVID. We'll also be hearing from Ayala Meir, who is a senior manager of the Family, Children and Youth in the Community Division. She's a social worker. She has a number of roles responsible for domestic violence, poverty, and she will be followed by Professor Orly Manor, who is the chairwoman of the board of the Israel National Institute for Health Policy Research. She's also the president of the Statistics Israel Forum. Please, you're invited to come up to the stage. קודם כל, תודה רבה לפרופסור מייקל מרמוט. שלא ניקח את זה כמשהו כמובן מאליו, אני יודע שלא היה קל להגיע הנה. תודה על המסירות שלך. אנחנו התייעצנו איתך במהלך ארגון הכנס הזה. העבודה שלך מעוררת השראה, ובאמת המושג הזה, הרעיון הזה של ערים בסגנון מרמוט, באמת זה רעיון נחמד. אולי כדאי להתחיל בנגב, ובאוניברסיטת בן-גוריון אנחנו דנים על כך כבר שנים. And now I will move over to Hebrew. So we have a very distinguished panel sitting here before us. I would be very happy to call upon Ayelet to begin, because together with the Strategic Council and with Gidi Peretz, who is sitting here very humble as always, and many others who were with us, and in a moment we'll see their names, and Professor Orly Manor, who coordinated with Professor Yehud all the different committees on the different indices. I think we worked for more than half a year, and I'm so happy to inform you that we have reached some sort of interim recommendations, one might say. We worked again through COVID and through some difficult and precarious times when we all had the feeling that we didn't really know how long the government in Israel would last. And again, this is unrelated to any political stance. That instability was undoubtedly also a part of our incompetence to push forward and promote different issues. But this is the time to say thank you to all the professionals. I think there are those civil servants who hold that tremendous knowledge throughout time. And I think that without you, we would not be able to think of some sort of a continuation. Of course, the ministers come in, take office, show, set the stage. But again, from 2010, Ministry of Health established this unit that we're talking of, and many things have moved forward. And Professor Marmot presented all sorts of things, and I think we do many things in light of what he has said. So Ayelet, I would be very happy if you came and presented the different issues, and then we'll present the recommendations to you. Then we'll move over to a discussion. Okay, thank you so much. Hello, everybody. Thank you, Professor Davidovitch. Thank you for this very brave cooperation, if I may say, and brave partnership. So let me tell you how this committee was founded and the discussions that we hold. So a previous strategic committee ended in 2020 in the middle of COVID, and of course we couldn't build a new strategic plan. However, I would say from about 2021 I took this position, and we presented our work plan, and we understood that one of our objectives was to build some sort of a committee that would build the next strategic plan in terms of inequality in health. And we contemplated about today, and Nadav, again, you again agreed with us, and also there were also our Director General. We supported you as chair. We're so happy we chose you, because I saw the recommendations of the committee, but again, beyond that, I'm so happy to be thanking you, because what Nadav will present, and it will show you the team members that were part of very active committees. And till this day, they convene and promote different issues. And we're talking about people from the health system and from different government ministries and other partners that have been working with us on different topics. It was very important for them to promote all these topics on on a personal level, and it was also part of their professional role. That said, in the last 6 months, we've been working on creating some sort of superior strategy, 22 to give response to the future health system. It makes no difference what we do within the health system. Things take time. That's how it is. So as far as we are concerned, thinking ahead, planning a decade ahead strategically, we thought it's very important. It's still a very significant objective and mission. And the way this was defined, and by many who took part in this process, in the coming Thursday, we will be presenting the recommendations of this committee. And I would like to read this out to you. It's basically increasing equality in the health systems and increasing longevity. We had a lot of discussion within the committee, and we talked about how we can take this leap forward, because as Nadav said, from 2010 we have dealt a lot in decreasing discrepancies, increasing equality, but we still believe that there's so much to do. Nadav will show you some statistic from the inequality report that was published today from the Ministry of Health. Indeed, there is so much work to be done, and what we decided to do was, again, to put this in that superior objective, and we defined 4 areas, strategic areas. Each one, again, increasing equality will be the leitmotif, writing through all these different principles and working through different channels. Hopefully we'll be able to take the leap forward, because we have to tackle this topic. You will see in the recommendation that Nadav will present to you, followed by Professor Nachman will talk to you about the ministerial work, that many topics were promoted in recent years as part of the previous strategy and the policy of the minister and the Director General, and understanding how important this topic is. So again, we've started acting on many points, and we have done quite a bit of work, and it's clear to us that, again, this is only the beginning. So let me just take the opportunity to thank Professor Ash and the member of the committees, and Professor Davidovitch, the chair, Gidi, Anna, who have been leading this issue in a very wonderful way. Thank you to everybody.
Thank you very much, Ayelet, for this partnership. I'd like to say something else that is important to me. This conference is a conference, it's an annual conference, an international one, and it integrates also with the 40th anniversary of the Taub Center. And for me, Avi, personally, it's very exciting. It's not at all trivial that a decision was made to take the issue of health inequality and as the main topic. And I believe that this really connects to the Taub perception of contemplating health, not only its narrow meaning, but rather in the wide range fields of interest of the center. So we have here this initiative, and it is something that Taub are leading internationally and nationally, and of course all the heads of the other programs. And these things integrate wonderfully together. And I think it's a wonderful example of how this research should be conducted and how things should be looked upon. As Ayelet said, we did not start in a vacuum. There is a very deep process, deep-going process. I've been part of it. You can see this compass. I have to mention Dr. Shlomit Avni as well, who was supposed to be here with us, but is now participating in another venture of the welfare ministry. She used to work at the Ministry of Health. And you can see now, you can see the world perception, the framing of our addressing the periphery, the early age, racism, things that connect very much to what Professor Marmot presented before, and concrete topics such as regulation, various economic incentives, the private and public relationship, addressing the needs of the person within the community, the perception that we call also health in all policy. And as you can see, many things happened. Unfortunately, some were indeed implemented, some were stopped, such as the Commission on Contending with Racism. It was a very bold step of the Ministry of Health, but for several reasons, including the COVID, this is somehow went down. And I am aware that the Ministry of Health is now trying to address it again. The issue of racism, and racism is a very wide spectrum. It exists in every state, and this is something that if you don't address it, if you think that if you want to address it, it will somehow disappear. Well, this is of course an illusion. Unfortunately, it is something that is part and parcel of every human society, something to be addressed. Racism towards patients, and also that of patients toward the personnel treating them. And this is through all the walks of life in Israel. And it can be an example, but there are many things that can be done. And I hope that in the recommendations I should submit to you in a moment, these things will be taken into account in a structural way, intrinsic way, and not only, one event here and there, but something much more structured. So the aims of the Commission, when it was appointed, to determine recommendations in terms of interventions aiming at reducing health gaps and so really the social determinants of health. And I'd like to thank you. Without you, this thing would have not have happened at all. I'd like to mention Dr. Yanai Krenzler, who also helped us, many other people. I'm not going to review all these names, but you can see the wide spectrum of participants, both from the Ministry of Health, from the health system, outside of the health system in terms of welfare, local authorities. And I think that really the strong point of this committee is its composition. Today we will present to you mostly stage A, which were the more short-term recommendations, And then we started also crystallizing the core issues and strategic recommendations for the next decade. We divided into 4 commissions. You see that the health services, healthcare are one of them. There's also the governance, collaboration and strategy, infrastructure and various indices, and the social civic society and the rights of minorities. There is a certain superimposition of things, but these are things that are not in a silo. And these subcommittees are also meant to update each other and work together. This was one of our challenges. How did we work? Concentrated days of work, meeting, also Zoom meetings, consulting Professor Marmot. All along, Professor Marmot, if we committed mistakes, they are ours, they're stemming from us, and the good things are to be attributed to you. And all along, we examined how to prioritize. There are so many issues. We spoke about the extent of impact on inequality, the chances of being included in the coming budget, which did not happen eventually. And you can see the 6 top recommendations that I will speak about. We spoke about the goals and measuring criteria for inequality. I'm sure that Professor Orly Manor will also relate to that. Also, Professor Daoud. All the idea of institutionalizing the health issue in local authorities. Professor Marmot also related to the issue of local authority, the whole issue of poverty, the exhausting of rights and increasing outreach, the governance in the Ministry of Health, to reduce inequality, and also the early age. There is a lot that is being done, but there's still a lot to be done yet. So just as in a nutshell, the report also was approved by the managing director and is about to be published, I think today, officially. You will be able to see there all these things. So defining goals and measurement systems to reduce and repress inequality in health. The issue of transparency. Dov Chernichovsky was mentioned here, of blessed memory, who was head of the health policy in Taub before me. And he said that with all the contentions of the HMOs in terms of beds, etc., there is a great gap in the investments of these HMOs in the various areas of the country, and this is not transparent enough. And you know that the light of the sun is the best disinfecting agent. Now, institutionalizing the health issue in local authorities and regional ones. Here the Ministry of Welfare, the Ministry of Health joined hands. The Ministry of Interior, sorry. We had signed a chart with the Ministry of Interior. Health portal information is much more accessible, and of course the climate crisis also has an impact on the local authorities. The issue of poverty is a critical issue. We're talking about vulnerable segments of the population, be it the elderly who live in poverty, those who have no status for whatever reason, the homeless. Developing digitized instruments, digital instruments for those populations, poor populations, to render health information more accessible, expanding services, exhausting the rights, and increasing outreach. In my opinion, the Ministry of Health has really gone very much forward in the cooperation with the civil society. Instead of fearing them or being in conflict with them, on the contrary, joining hands, even if that segment continues to criticize the ministry, that's okay. So the issue of governance was also very important. health promoting professions. I don't know if you know why this is not yet regularized in Israel. We've addressed this for many, many years, but it's important. If, for instance, we want to have health promoters in communities, this has to be defined in a much better way, and also in expanding the basic insurance. Dental medicine, for instance, was very much in consensus. Now, increasing governance or improving governance in the Ministry of Health in terms of reducing inequalities. We need many more people. We need a department with appropriate budget, a permanent system for fighting poverty. And lastly, perhaps the most important issue, reducing inequality in the early ages. And here the situation is pretty bad in the mother and child clinics, and they do not receive resources mainly due to legislation. And this is something that really needs to be addressed. The Ministry of Health addresses this. We've seen during COVID also the great importance of these mother and child clinics. What are we going to do? And I'll conclude with that. We continue to work. We wish to expand the existing recommendations that we just mentioned and buttress them in terms of policies. You can see many things on this slide. And we wish to take very specific issues, the issue of climate change and its impact on the poor populations. Another issue which I concentrate under the President of the State with Dr. Karni Kargi and others, committee that addresses the climate change and health in poor populations. Professor Marmot mentioned that energy crisis, the impact on health, etc. The issue of old age, of aging, which is an increased pace process in Israel. Here, COVID has given us a lot of insights, and of course, strengthening the universality of the system. Today, we learned a new concept of proportionate universalism, but how can we buttress and strengthen universality in a way that is adapted to the needs? That is one of the biggest targets and goals and challenges. Thank you to the Ministry of Health for having given us this opportunity. Gidi, thank you again. And we are going to open now the debate. Thank you very much.
לפי סדר הדוברים, אני חושב...
So the order of speakers, I think Ayala will invite you first. Or Nachman, would you like to start? Perhaps we'll start with Professor Ash. You know, sometimes you may want to have the last word, so I'm giving you the prerogative. You want to start? Okay. Professor Nachman Ash, Director General of the Ministry of Health. Hello, everybody. Good morning. First of all, I'd like to congratulate you for this conference. I'd like to thank you as well for addressing this issue, which to us in the Ministry of Health is of great importance. As I understand, I did not hear the entire lecture. I came towards its end. This issue is a global issue. It has become much more salient and clearer during COVID. This issue of inequality, health inequality, has become very salient. We could see this reflected in morbidity and in mortality, the areas or the sectors in which we are not good enough in providing health. They suffered more of morbidity and mortality, and when it becomes so tangible, it is definitely much more salient. Of course, it's reflected in other data as well. We in Israel are operating on the basis of the national health law, health service law, or health care law, as it has already been said, and I was happy to hear from Neil that perhaps it is not entirely objective, and I am saying this to your credit, of course, but I believe that this is our feeling also in the ministry, where we are addressing this at all times. and trying to promote it, but at the end of the day, beyond the mere declaration in the law of ensuring equal health care, this must be backed up by operations on the ground. And that's what we are trying to address, to identify inequalities, to identify the weaker sectors which suffer from inequality. And not only the sectors that are familiar to us, but also the populations of the foreigners that are here, migrant workers, etc. This came up as well. And measuring inequality, Professor Manor will address that. And to define very clear goals and targets that are measurable, that can steer us to achieving our aims. And our outlook should be a long-term one, and we should define what exactly we wish to do along the coming years.
בזה עסקה הוועדה, ואני שמח שהיא...
This is what the committee addressed, and I'm happy that it set for us a sort of a modus operandi for the coming years. And it is quite clear to all of us that inequality in health has to be measured in health products. And this is not only an issue of how much to invest in one field or another, and are the investments equal in the numbers of physicians in one area and another, are they equal? But we want to see our impact on the outcomes of health, and this is what should direct us and what we are doing. So it's not only an issue of let's give all the same, but if we identify a problem in the outcomes, and we do have such things, we have to invest much more in those places that we wish to promote. As it has been said, the Ministry of Health has been addressing this for a decade. When we set up the Department for the Reduction of Gaps, and I'm happy for the initiative of setting up this department, and also with what they've done along the years. Our health system is very much engaged in the here and now. And sometimes, things that literally fall on our desk, and we must address them and must provide immediate response to them. You hear a lot in the media, but there are many issues that do not get to the media. And we have challenges that are on our table for many years, and we, including in the last year, in the ministry that I have been leading, we have addressed this, whether it's the shortage of treating personnel, of hospital beds, the need to carry out a considerable change, significant change in the mental health system, the continued hospitalization, etc. All these things that the Ministry of Health should address and does address. And now in the last year, under the leadership of Ayelet, we are trying to look forward to decide on the strategy of the ministry, and also in those aspects of equality, we are trying to look in the longer term, see what are the right solutions. When the committee brought to my desk its outcome, the great challenge was to contend with what has been mentioned here, the issue of the continuity of the political continuity, the government continuity in Israel. I don't wish to go into politics, but all such processes of a change of government, dispersion of the Knesset, stops what we are doing dramatically. And a few months ago, we spoke about it, and we spoke about the fact that we would have a budget for next year. We are going to introduce into that budget the required elements, including this program, and try to promote these issues. And here again, we are in November, we should have been already deep into the preparation of the 2023 budget, and we don't have any. So I said, okay, let's try to promote all the issues that can be promoted without budget, without legislation, without the Knesset, in order to start to launch this process. And this is what we've started to do. Also based on the understanding that the budget eventually will be placed on the table of the incoming government, hopefully as soon as possible. And there too, we would like to introduce things to have an impact on what will be the decisions of in that field. I'd like to touch upon a few points. Well, I could have touched upon many, but I'd like to relate to the issue of transparency and measurements that Professor Manor will address more in greater detail. In my view, it is very important. The various indices, we can see that the various measurements when we check in hospitals and to set equality indices, that is a very important part of our task. I wouldn't go into detail, but for me it is of utmost importance. It was mentioned, the issue of the local authorities was mentioned, and this is something that I can tell you that I personally learned this during COVID times when I was the project leader of COVID in Israel. There was a lot to do with the local authorities, and I understood the power that they hold to move things forward, certainly in the context of COVID, but we now understand that it is much more wide-ranging. They have the possibility to have an impact on health issues as well. Perhaps this is not news. We already have programs which are being elaborated with the local authorities, but the issue is how to expand those. How do we reach also the weaker local authorities, because the stronger ones are already engaged, already involved. And this is one of our challenges. We define this through clusters, and that has to be expanded. We had a sort of a pilot in clusters, and we have to expand that as well, have more clusters, and reach the local authorities themselves. And this should be one of our targets. This, of course, calls for quite considerable resources, but also an orientation, proper orientation of activities. You also mentioned the issue of poverty, and we very well understand the connection between poverty and health. And this is a task that must be placed on our desk as a priority very clearly. The committee said this, and we have to relate specifically to the poorer segments or sector of society and see how to promote health in those sectors primarily, and not only what to do, but how to change habits, what supports the change of habits. Quite a lot of challenges ahead. Work with the civil society has been mentioned, and I definitely agree with the fact that the Ministry of Health has gone forward, has learned to work with civil society, and I always say that there is still a lot to be done to go forward, to improve this activity. We understand that there is a lot of power in the hands of civil society, and I really look forward to this cooperation being further expanded. This is also something that we learned, at least in part, from the COVID period, the pandemic. Now, strengthening governance on the regulatory aspect of the Ministry of Health, the ability to impact, our ability to impact through the fact that we have a regulatory power, that has to be strengthened in some places so that we can really do more and better things. The early ages and the mother and child clinics, that is a great source of pride. This is a system that was set up in Israel many, many years ago, and it has a tremendous impact on health in the country, in Israel, and also on equality. But as it has been mentioned, we have to reflect on this system, see how to contend with gaps in it, existing gaps, and how do we provide a response. And I can even expand the issue of the early ages to even somewhat more advanced ages in primary schools. And we were in the past in a better place with the health being more present on school premises. We are now today trying and aspiring to promote this issue as well. And this brings me to the last point that I wish to stress, and that is the cooperation with other systems that have an impact on health. And I'm paving the road for the next speaker, the issue of welfare, first the issue of education. We are working very nicely with those ministries, but here too, I believe that we have to really take this cooperation forward and to submit programs, governmental programs, which connect all these ministries together. Our ability to have an impact on equality on the level of schools through schools and through welfare is very important, and I'm calling upon the incoming government to place this as decide that this is one of its priorities. As you can understand, a lot has been done, and still a lot can be done, and I hope that the decade committee that has been mapping and planning the next decade, I hope that we can meet in a decade from now, look back and be satisfied that we have really done good things and things that can be measured and placed clearly on the table. Thank you very much.
תודה רבה, פרופסור.
Thank you, Professor Ash, for all your support. And I'd like to invite now Ayala Meir, who's the senior manager of the Family, Children and Youth in the Community Division Ministry of Welfare and Social Affairs. Good morning. I've just said quietly to Professor Ash that he saved me 4 minutes of the poor 8 minutes that I was allocated. He said many things that I was supposed to say, but I've been asked to give you the outlook of the Ministry of Welfare and how do we try to promote this issue of reducing gaps. And I'm happy to say that many of the things that we've been hearing from this morning, including the very interesting lecture of Professor Marmot and what we've heard after that, really echo many things that I'm going to present to you and ideas that we are trying to promote. Thank you for inviting me. Thank you for wishing to hear our side of the story as well. Let's start with some data. Just the Ministry of Welfare addresses every year some 450,000 households in Israel. If we translate this to people, it's about 1,200,000, 300,000 people addressed by the ministry on a background of life crisis, various risks, and poverty, etc. And we consider something rather astonishing. On the face of it, many people are astonished to hear that the Ministry of Welfare, until a few years ago, did not place poverty or addressing poverty on its desk. Of course, it addressed people who are poor, who are impacted by economic distress, but it wasn't one of the main priorities of the ministry. And when we look at the data, we can see that about 30% of those families or households addressed by the welfare system come to us because of poverty. When a person comes to the welfare department in a local authority, he's being evaluated. There's an intake trying to understand from that person what is the background, what is his or her central need, so that intervention can be planned efficiently. And once we understand, we introduce the data to our computerized system. And so 30% come because of real material poverty or economic distress of one kind or another. And we also know that 70% of the people who are addressed by us are those who receive all kinds of complementary income to complement their basic income. And when we prepare intervention programs, we do that on the basis of what the person brings us. If they bring various situations of risk, difficulties in parenthood, frustrations with the children, or in the marital life, Nir mentioned that we also addressed violence in the family, sexual abuse, etc. So poverty is somehow set aside or pushed aside. If there is sometimes a problem in understanding that I can assist a person also if they come to us because of poverty. This is what used to be until about 7 years ago. It was already been mentioned, but I will say it once again, that when we meet this population that is less educated, less employed, earning less significantly, and I don't have to say that because it's been mentioned many times that the poorer you are more excluded from proper health services, transportation services, etc. The more you are in the periphery, social and geographic, you receive less and less proper health care. So the health problem, of course, increases when people are under the poverty line. These people are less free to address health issues. They have to contend with survival issues. There are also more barriers. They are more distant. They have to travel longer. Professor Marmont mentioned it this morning. The farther away you are from proper healthcare services, we have to prepare for you the way to get there. And if public transportation in your area is less optimal, you arrive less. If you have to take 2 shifts at work or to work in 2 places in order to support yourself, to sustain yourself, you have less time to address your health issues. So this is quite clear. And of course, you buy food that is of lesser quality. Higher quality food costs more than junk food or the lesser quality food. So just as a short outlook, we're talking about 2 budget lines which we are making accessible to the social assistance services in the local authorities when they need to provide a one-time assistance. You can see that in the 35 million shekels that we allocate to the local authorities according to various criteria, quite a high percentage, almost a quarter, it goes to help people to get medical assistance or to acquire medical equipment or transportation to medical services. If we're talking about health insurance or what the ministry is supposed to do, this is something that is required to be done. And because we know that the health system cannot finance 100% all the healthcare systems to be provided, especially when we're talking about the people under the poverty line, so they come to us, to the welfare system.
So as I mentioned before, poverty has been again on our table as a profession for 7 years already. We created a system called Taking Air in 13 different localities and local councils that were chosen by specific criteria that are either poorer in comparison to others. And this is an entire system that we are very proud of. It is that sort of banner program, that flag program of the ministry. The paradigm that leads the way is social work that is aware of poverty. And let me say proudly that, again, collaborating with the Ministry of Health is a wonderful paradigm. It is a paradigm that talks about poverty in 3 circles of deprivation, not only materialistic, but also in opportunity. We mentioned it a lot in the morning. And of course, a deprivation of symbolic capital. You know, they have less of a social status. They don't feel that the different, systems even take them into account. they perceive themselves as less worthy. They have a lower self-esteem because the public at large and the service providers oftentimes relate to them in this manner. And there are so many different examples. I don't have the time to mention them all. But what this outline or system created in a very significant way is it created discussion circles between different ministries, especially the Ministry of Health and Dr. Shlomit Avni, who is in the Ministry of Welfare now, but used to be in the Ministry of Health, and Erika Dar, who was head of strategy and then moved over to the Ministry of Welfare and is no longer with us. But in the past, they were our partners, very loyal partners, when this process was underway. So in a very unique process, and again in consultation with both ministries, we defined indices of intervention on a number of axes. I'm so happy this was included in what is called the decade report. There were many recommendations. I don't want to expand on everything. It's all on our website. But you can see here are some recommendations for solutions. We mentioned some of these. It's not the responsibility of the welfare services or the health services, to deal with inequality or those who live in the poverty circle, but it has to be a joint responsibility of, again, the local authority as well as civil society, which was mentioned. We believe that one of the solutions is expanding the health basket to people living in poverty, and having that national health law, adjusting it so that it will be universal, so that it will create that correct universal basis. Anyone living in Israel will be entitled to receive health services, but there should be, again, a more differential or again, more progressive attitude towards people who are poorer. We talked about creating mechanism. We talked about the importance of the local authorities. Welfare services, again, are situated in different localities by law. But when a specific department wants to create collaborations with people from the health services on a local level, it has to work with 3 different HMOs that have different models, that have different policies, and it's very difficult. So the more we're able to give that local solution for problems, so too we will be able to benefit the local population. And of course, having collaboration and synchronization between different bodies to create joint meetings, joint staff and committees, and work together with the population. Thank you. Thank you so much. I'd like to call upon Professor Orly Manor. And we have to say that, before many of us even dreamt of dealing with inequality, I think your first articles, Professor Orly, can I tell everybody when you started publishing for the first time? When was it? Oh, couldn't hear her, sorry. Orly, please. She was one of the heads of those committees that dealt with indices and different assessment and measurements. Thank you so much. So in 1990, I came back from a postdoctorate in England, and I said that I want to research gaps in health. And people said, you'll have nothing to do. In January, I celebrated my 70th birthday, and I'm very busy. So I am very happy to be talking in this conference. First of all, let me say a few words about the committee. It was divided into subcommittees, and Professor Dayo and myself headed a subcommittee titled Infrastructure and Indices, but dealt in many aspects, and we had to start working. We organized a multidisciplinary team. Again, there was representation for most people, and we said to ourselves, how do we go about doing this? How can we divide this up into groups that we can work with? So we divided up into 3 different categories. The first category was economic tools, and we do deal with economic tools in the framework of the health system. And I will mention the first recommendation that we had, which actually talked about the capitalization formula, that is the main economic tool in the state of Israel to finance health. It is accepted in economics that it's difficult to acquire 2 objectives using one tool, one instrument, and yet our group thought that it would be feasible to use that capitalization formulation to diminish gaps. Now, the idea is not to change that basic perception, but we can actually make some changes. You know, people said timing is everything. I think timing and connections are everything. You know, connecting, joining efforts, and indeed, we prepared ourselves. We thought about a plan for allocation. We thought it would be a great time. We discussed this really quickly. We convened, and many of our recommendations were accepted. I hope it will be, again, efficient. So what were the recommendations? First of all, again, geographical periphery. Today, in that whole formula of capitalization, there is priority given to the periphery, but the compensation isn't great. There isn't really some sort of significant incentive for this operation. So first we have to increase the incentive. The second thing is we have to upgrade the definition of given compensation to geographic peripheries, and for this to include social or economic peripheries as well. It's very important, not only the distance from Tel Aviv, the means, complementary means we're not inside, and also that the HMOs have to report. We basically said, okay, so this money it's undedicated, it's unmarked, but we can't verify what the HMOs did with the money. So the more elaborated the reports will be. If we get, again, reports on the basis of geography or the basis of a periphery, this would be an excellent tool. And the final report that we published, and we've already seen, again, an improvement, Nachman. Another recommendation was given, again, more weight in the formulation to the elderly in weakened societies. Could be complementary income or some sort of a disability benefit, but this has to have more weight in that capitalization formulation. So the team that dealt with that, again, is setting forth, continuing. The other, again, team started talking about, again, interface and human resources. Let me just briefly talk about some of the recommendations. As to interface, we talked about welfare and health. In fact, those working in the HMOs, they found themselves during COVID in such a situation where they did not have the data, did not have the figures from COVID, meaning the whole issue of interface in infrastructure, in thinking, maybe even to have some sort of, again, collaboration, precise cooperation of resources. We talked about this as well. So between health and welfare, and also the health wants an interface with education. And also, as far as resources are concerned, we wanted, again, more positions for health officials and health employees, and an investment that will allow the public health services to promote and execute health plans that are customized and made intentionally for diminishing inequality and gaps. So this was mentioned. Again, the baby health care centers were mentioned, HMOs were mentioned. All these recommendations are important. Another area that I want to focus on is the indices. So Sir Michael, of course, he illustrated to us to what extent measurement over time, assessment over time gives us, again, the feeling whether we're in the right direction, what we have done. The Director General talked about the need to identify where we as the health system have to intervene and invest. Here too, let me say something about timing and connectivity. So Nir Kedara, the new director of the Taub Center, first of all, lots of luck. So Nir, when he was, again, the vice director in the department, and greatly invested in thinking about diminishing gaps and inequality. Now, he came to the National, again, Council for Health Policy, and he asked for our assistance for the following research. He said, let's conduct a study that would define a basic set of indices so that Israel would be able to examine itself and see what are the gaps that exist in the health services. So we can talk about child mortality, you can talk about longevity or life expectancy or treatment of of diabetes or obesity. So they set forth with a study. The center said this was exactly right for what the center does, and Mrs. Cheli Maron headed this study. We formed a steering committee. All the players assisted in this, and then when COVID entered this again, and despite the corona, this ended on time. So now we have an agreed upon set of indices, and it's no trivial matter when Israelis actually reach a consensus. So we have a set of indices or measurements for the next 5 years at least, and the state of Israel can now examine its progress and how it's moving forward in terms of the gaps and discrepancies. Now, who's going to measure this? Who will examine this constantly? So we convened with the Director General. We asked for his approval. He added 2 indices. So we, again, no longer 10, there are 12. There's that Director General Index. So we have 12 now. We have an entire set of 12. And that's as far as the measurement is concerned. And the reporting, it's all conditioned on that national program plan for assessment and measurement of the health situation in Israel. So it begins now. In the next 5 months, we are going to start seeing the products. Now let me say that national plans for, again, the quality of health, the treatment or medical service that we, the Israelis, receive from the HMO. That's no trivial matter, of course. The fact that we're able to, give information about these indices vis-a-vis socioeconomic status. Now, I don't know if you know, the HMOs don't have all the information about, again, socioeconomic or education level of all its clients. If we want to map these out according to these variants, as Sir Michael showed us, again, this is no easy feat. So you can use maybe place of residence. You can somehow divide up the state of Israel into zones, and then we're using where, again, place of residence is somehow an indicator. So an index that actually took first place of those indices that the research recommended was the quality of treatment for diabetes. That received the highest grade. Now I can share with you, okay, this is hot from the oven, the updated figure about the gaps concerning the quality of treatment for diabetes in accordance with socioeconomic status based on the geography of residence, from the 25% on the top of the population and the lower decile. I'm going to look at those people who do not have unbalanced diabetes. It's not treated. So in the top quarter of the population, only 5% of those diabetics in Israel, again, the disorder is unbalanced. But in the lower decile, it's much more, right? It's 15%. Threefold. It's not, again, I'm comparing the 25% lower part of the population. Now, again, I've researched gaps and discrepancies for over time, and I'm saying we don't have to keep, I'm saying don't change the law about taxation of sweetened beverages. That's a recommendation that's just come up recently. It's an important tool in our fight against diabetes and also inequality. The committee also called to represent the different products of that indices program according to geographic area or zones or natural areas, to expand this program to infrastructure indices so that we'll be able to see how the services are disseminated, whether it's specialists or centers for child development and so forth. When we set out, we thought that the recommendations would be put into the budget. But again, all an issue of timing. Reality went its way. It didn't enter the budget. There is no budget. But undoubtedly, we have to continue working on this plan. We need, again, a ready strategic plan the minute the government is formed, and we have to continue talking and requesting of the government to please deal with diminishing discrepancies in the health. in the Board of Government. Again, it was discussed on Friday that, again, the ministers in Britain called the new Prime Minister Rishi Sunak, right, to please honor previous obligations or commitments by previous governments as far as diminishing gaps is concerned. So I'm calling out to you as well from this podium. Thank you so much. Thank you so much, Orly. Thank you to all the panelists. And now I'd like to say that all the consensus of all the people from the health system, also ultra-Orthodox personnel and people we've worked with, will start again talking about the taxes imposed on sweetened beverages. We ask you not to remove it. Of course, maybe it has to be done in a more balanced way. We do want there to be a healthy, food basket for everybody. And we are studying this as well. And the final panel today will talk about food security. And I think this connects to that point. I think it shows us the need, again, to take that broader perspective. For example, if we talk about food security, to provide healthy food, because unfortunately, this is not always the case. So I think we have to relate to this, and the final panel will relate to this. Thank you so much. Again, we have, a long way to go, much to do, but we can look at the full half of the cup, and I'm happy to open up the floor to questions from the audience. Professor Chagai Levin.
תודה, באמת מרתק.
Just into the mic, please. It was very fascinating. I hope you remained for the final panel. But one of the things that we spoke of yesterday, we talked about inter-season food securities at Hebrew as well. We talked about food as medicine. And let's take the example that you gave, Professor Manor, relating to the treatment of diabetics, meaning diabetics, if they continue to eat unhealthy food, they can't balance out their diabetes. So I'd like to ask the panelists, how can we assimilate this connection between welfare and health, not only as far as poverty, but also lack of food security? Today, the HMOs don't have that information. For example, the diabetic also has to deal with food insecurity. And also the patient doesn't always know all the data. So how can we bridge that gap? We talked about really something interesting yesterday. Maybe there should be a prescription. A doctor will give you a prescription, and you'll be entitled to getting, let's say, a basket of fresh fruit and vegetable. Maybe we should, move over to the next stage, and maybe this will be the next stage of bridging the gaps. Maybe, again, that prescription could be part of the basket. Yes, health basket.
כן, עובד.
It's a very complex question. I could say there are nutritionists, dietitians, and we refer them to nutritionists, and then they recommend what the client should be eating, right? But I think this is a combination that begins sort of with awareness, and I think there are many challenges that are cultural. Again, making sure this is part of our awareness and our consciousness. And I see it as our role as well. There's also an issue of ability or capability, right? The financial capability, can I... I never understood why something more healthy is more costly. Never really understood. We have to make sure in one way or other that if people who can less afford it, they should be able to buy healthier food more easily. So maybe again, we can do this through your idea of a prescription. It can be some sort of a healthy food basket. But I do think we have to think of possible solutions for these problems with the understanding that it is one of the problematic areas. I don't have any, magical solutions now, up my sleeve. We do have to think about it further. I just want to relate to the committee about, again, sharing information between the health ministry and the welfare. There is a problem of sharing information. But let me say that in, again, the trials that we did and joint programs or joint processes that are underway, we even tried, saying to a social worker that when the social worker meets the family, they should ask the family about the health situation. It wasn't even something that that was considered previously. I talked about it with Professor Ash before, but I don't know if there are physicians that do it, maybe there are nurses from the health public services that do it, but I don't know if it's written in their protocol to actually ask about their welfare situation, the economic situation of a client that comes to them. Or let's say a doctor who writes a prescription. Does the doctor check out if this family is actually able to buy the medication? So again, these are tiny, these are changes even on the level of the behavior and the professional protocols of all these professionals within the health system, just to ask. Don't be wary of asking the question and then dealing with it, and then maybe thinking together with the patient, also on the part of the health services and welfare services. How can we help this client receive maybe a less costly medication, or maybe somehow again get services from civil society or NGO or from the community to be able to get these services. I think this is a little difference, but it can make a very big difference. Of course, there's also changes done through the legislation channels, but a behavioral change can really make a difference. As Professor Ash said, we should have awareness not only of the actual people, but awareness of citizens, and also the awareness, again, professionals should have awareness as well. Let's just add and say that the head of our department that deals with promoting nutrition, and in recent years, how nutrition, again, the whole issue of nutrition has come up also among the public at large. I think one of the tests, the initial test, is supporting different zones or different areas with all that relates to nutrition and promoting activities that will promote nutrition in schools and in different frameworks. And again, also in terms of collaborations with us. Again, this is a budget that we received from the different taxes on sweetened beverages, as was mentioned. We have to take this process further and use it better. Let me just say that we have been discussing that with the Ministry of Economy with regards to different food items that will be part of this healthy food basket. I placed it on their table. Hopefully we'll be able to promote a few of these issues. We have time for one more question. Dikla, I think you basically maybe answered in part, but I think bringing it into the education system, even to early childhood, into kindergartens, and talking to them and talking to the parents and the children, what is healthy, what is not, and also environmental behavior that again may be related, that can impact health. You can define these objectives even in early childhood, bring it into the education system, because even people with money have health issues and are not always aware. And by the way, it's not always more costly. For example, meat is not necessarily healthy, but it's very costly. And so it's all about information. Do you have such an intention? Again, to implement it already into the education system, but let's just take one final question and then you'll be able to relate to what was our Dikla Aharon Shafran. Thank you so much for covering our conference on Reshet Bet today. Thank you. My question is as follows. Are there significant figures and statistics about the results of that tax, the taxation of for sweet beverages. Do you have any figures already since the short period of time since the time this tax was imposed, and whether the results have been made accessible to the ultra-Orthodox leaders that now want to annul this taxation? The second thing has to do with the program of the Decade Committee. Does it include diminishing, again, health literacy, for example, in the Arab sector and the ultra-Orthodox sector? So as to your second question, yes, the answer is yes. But I do want to say something very important, because literacy and health education, they're both very important, and we do have to invest in these. But we already have experience of a few decades that this is not enough, because without the structural changes, without the incentives, which can come about through taxation, but it has to also be done by, again, making our food basket cheaper or changing the urban planning, we will not be able to move forward. After decades that we again dealt with health education, which is important, but on its own it does not suffice. As to your first question, I can tell you what I know, maybe some things I don't. We still don't have statistics. There are initial figures. Again, we've seen a decline in the consumption. But again, there's a lot of systematic reviews that were done that taxation imposed on sweetened products. And I think Professor Marmot dealt in this as well. I think it was shown that this is an important tool. It even decreases, just as a rule of thumb, this is that the higher the percentage of, of those who consume it also decreases. This can't be the only tool. Maybe we have to again take this tax and maybe use the money for this in order to explain about health. And Professor Levine is here, he's the head of the union. But we incorporated a working team of ultra-Orthodox men and women who were for this tax. And unfortunately, this tax, we started working on this when Litzman, who's ultra-Orthodox, was a minister, and then he was perceived as a hypocrite, which is not true, by the way. And even the Arab sector, sweetened beverages, the situation is even worse there. And as far as diabetes is concerned, very severe. We do a lot through media, the website, Kikara Shabbat, and different ultra-Orthodox newspapers. We started working with these people during COVID, and Ronit, again, is a real turbo. And she does so much work with the ultra-Orthodox sector. Unfortunately, the ultra-Orthodox politicians and maybe the non-ultra-Orthodox politicians, for their reasons, somehow connected it to the ultra-Orthodox sector only. But this is a tax that actually benefits everybody, and it will undermine and hurt the ultra-Orthodox if it's taken away. There are a few proposals by ultra-Orthodox rabbis. They started, placing, water, and they started advocating drinking of water because the Torah is parallel to water. And remember from the Bible, she drew water from the well for Abraham's servant. So yes, water per se is a very significant notion and symbol. And we're playing into the hands of all those companies who kept advertising to the ultra-Orthodox sector in the last year because of this tax, trying to undermine the tax and showing how bad it is. But we do know that these sweetened beverages really have a bad impact on diabetes and on the health of children. And in 10 years from now, if somebody lights a cigarette, right, we'll be shocked, right? But 40 or 50 years ago, it was pretty regular that people in the back rows smoked their cigarettes. I think that in 10 years from now, just in the wonderful advertisement from the Ministry of Health, in that museum, you know what I'm talking about, we'll look at this whole issue of sweetened beverages as something crazy, and it really is crazy. And so, we all sort of are addicted to the soft drinks, right? Sweetened beverages. Same thing. Same goes for smoking. Sorry for this very long answer. I think the Taub Center knows that this is sort of my pet peeve, and this is very important to me. But it's a fascinating question, using this again as for changing behaviors. Just as to the other The Ministry of Education is a strategic partner. We already have different programs that are done jointly. We want to expand the collaboration. And as to the Arab sector and the ultra-Orthodox sector, we have, again, a program. It's part of 4 government resolution. It's a health program or plan for the Arab sector with hundreds of millions of shekels are to be invested there. We work with the local councils and again with the diabetes divisions in the HMOs and conduct studies, and we pay researchers again to research behavior in Arab sector. We call civil society to help us promote all these issues. We again built a portal in Arabic. And as to the ultra-Orthodox sector, we have again, this is a strategic plan, and maybe one day we'll be able to promote this plan at some point. So on this optimistic note, let's end this panel. I would like to thank all our panelists. Thank you very much. We will meet again, reconvene at 12. So drink some water, don't take sweetened beverages, and enjoy.